The APHINITY trial was designed to test the addition of pertuzumab to the standard chemotherapy and trastuzumab backbone that we have typically for many years been using for early stage HER2-positive breast cancer. It was designed to enroll a slightly higher than normal risk group of patients. It included anyone who was stage 2 or higher, but it also included some stage 1 patients who had tumors greater than 1 centimeter, or if they were greater than 0.5 centimeters, they had to be high grade or hormone receptor positive. And these patients were randomized to get either standard chemotherapy, and that could either be anthracycline-based or taxane without anthracyclines, that are standard NCCN recommended therapies, with trastuzumab given overlapping with the taxane, and then continuing to complete a full year of maintenance therapy. And that was the control arm, and the experimental arm had pertuzumab added to where trastuzumab was added. So it was dual antibody versus single antibody. The design of the study was a 1-to-1 randomization, and it was stratified on the basis of the type of chemotherapy received and other risk stratification factors. The main endpoint of the study was invasive disease-free survival, and it was powered to detect a fairly small but clinically significant improvement in that endpoint. So the trial enrolled over 4,000 patients and did, at the end of the day, show a statistically significant improvement in overall invasive disease-free survival. The absolute difference over the whole trial ended up being about 1.5% difference over the course of 3 years in invasive disease-free survival. But that difference was bigger in the subgroup of patients that had node-positive disease. So nodal involvement is probably the single most important prognostic factor, regardless of the therapy used. So going from 0 to 1 nodes, of course, is a big increase in risk, and every additional node, of course, increases the risk as well. So that is an important determination. For patients who have node-positive disease, I think that you definitely want to choose the most efficacious regimen out there, because the absolute difference that a patient will have in their disease-free recurrence is proportional to that overall risk. So generally for node-positive patients, I feel that therapies that have clearly shown an improvement over standard chemotherapy and trastuzumab regimens would be favored, in my opinion. So I would use a pertuzumab-containing regimen in anyone with node-positive disease, regardless of tumor size. Now, in someone with node-negative disease, then the tumor size does become important, and tumor grade is also important, and you look at them both. For example, someone with a 2-centimeter high-grade tumor, I think, is clearly someone that I would treat with pertuzumab-containing therapy again. Someone with a grade 2 tumor that is 2 centimeters, I think I'd treat as well. But then you get into the really low-risk patients, and these are going to be patients that have hormone receptor-positive disease and low-grade or low proliferative indices. And for those patients, I think it is a toss-up. The benefit for those patients may even be difficult to distinguish. We did see that in the subgroup analysis of the APHINITY trial that the patients with node-negative disease didn't benefit, but then of course the trial wasn't designed to stand alone on those findings. It wasn't statistically powered. So I generally feel that the benefit is proportional to the risk, and that it may be such a small benefit that it may not be worth the additional toxicities. The main toxicities that we encounter that have to be factored into this equation would be more diarrhea. I think that's probably the biggest difference from adding pertuzumab. In terms of cardiac toxicity, we haven't really seen much over and above what you would expect with trastuzumab. And there may be some other subtle side effects that you see more, like GI side effects and fevers and fatigue. So for patients who receive neoadjuvant chemotherapy and trastuzumab, or trastuzumab and pertuzumab, you do have an additional tool to look at prognosis, because we know that patients who do not achieve a complete pathological response, and that's defined by the absence of any invasive disease in the breast or in the lymph nodes. So any invasive disease in the breast, especially if it's more than 1 centimeter, or any invasive disease in the nodes, does portend a higher risk of recurrence. And this was particularly more striking in patients that have hormone receptor negative breast cancers. But even in hormone receptor positive breast cancers, it probably does suggest a higher subsequent risk of recurrence. So in that situation, I think that all patients should be considered at higher risk, and I would recommend using pertuzumab in the adjuvant setting for those patients. Now keep in mind that pertuzumab has already for a couple of years now been approved in the neoadjuvant setting. So if you are treating someone with a clinical, so preoperative stage 2 or higher disease, then they should receive pertuzumab with trastuzumab at least during the chemotherapy. And then most likely those patients would then continue to get maintenance pertuzumab the whole way through. But that does represent an additional tool that we have in prognosticating